today's episode of Oncology Data Advisor. Today we're here to discuss the recent NCPD activity that i3 Health currently has on our website about managing immune-related adverse events, or IRAEs, and the nurse's perspective. And today I'm joined by one of our editorial board members, Beth Sandy, who is here to share some additional updates that have occurred in lung cancer, as well as her perspectives in this area. Beth, thanks so much for coming on today.
Thanks for having me, Kara.
So first of all, would you like to tell us if there have been any new updates in immunotherapy indications in lung cancer since this was recorded about a year ago?
Yeah, so there's been a lot in that past year. It seems like, it's great in lung cancer. Things are exploding all of the time. And so I'll start with a new drug, tremelimumab, which I do not believe was approved back a year ago, is an anti-CTLA-4 inhibitor. And the only one that we had to date was ipilimumab, but now tremelimumab is approved in combination with durvalumab, which is a PD-L1 inhibitor, and in combination with chemotherapy. So it's a 4-drug regimen for metastatic non-small cell lung cancer. And it's a crowded space. There's so much immunotherapy approved in metastatic non-small cell lung cancer. I think this particular regimen, the toxicity is a little bit more than what we would see with just chemotherapy and single agent PD-1 or PD-L1 inhibitor, but still fairly manageable. And I think the interesting thing about their data is they had subset analyses in sort of hard to treat populations, like patients with KRAS mutations, STK11 mutations, where typically we have seen, lower survival and lower progression-free survival rates. And they had some compelling data in that population, in those subpopulations versus chemotherapy alone. So I think in the lung cancer community, sometimes if we see one of those mutations, which KRAS is targetable, but not until second line right now. So they have to progress on chemo and immunotherapy first. And so I think this 4-drug regimen might be a niche in that population of patients, and especially if the patient is fit and wants to be extra aggressive. Another new drug that has been approved that's in the immunotherapy space in small cell lung cancer is tarlatamab, which is a bispecific T-cell engager. And, it's interesting because these drugs have only been approved in the liquid tumor space. So this is the first time in the solid tumor space in lung cancer, and in small cell lung cancer specifically, a very hard disease to treat, very aggressive disease, we've seen this drug get approved. It has a whole host of its own separate side effects that, again, people who are used to doing, BiTE therapies and CAR T therapies are used to dealing with those side effects. Now, us in the solid tumor space are learning how to manage those side effects as well. But the data is pretty good in small cell lung cancer. Again, it's approved in that second or third line setting, post progression on upfront chemo and or immunotherapy. So it's a tough space to treat, and the data is pretty compelling, though I will tell you the administration schedule is really difficult. So we're learning, but that is another new drug that's been approved. And then the other thing that I'll mention is that, and there's other drugs that are not new, but have been approved in a new space. So we've really seen a big shift in the past couple years of moving immunotherapy to the neoadjuvant space, that preoperative setting. And a year ago, I know nivolumab had an approval there. I don't remember if any other immunotherapies had an approval there yet. But in the past year, we've seen a significant uptake of approval and uptake of use of drugs like pembrolizumab and durvalumab, both of which have been approved, I think, in the past year in this space. And these drugs are looking in combination with chemotherapy in that neoadjuvant space. And we're seeing really good, like, pathologic complete responses and pathologic, what they call it, but like majority response, significant responses. So at the time that they go to surgery, the surgeon, has less disease to resect. There's not nearly as much viable tumor coming out. And I think the idea here is also that we can catch, micrometastatic disease early. Boom, we're getting these people on treatment right away prior to going to surgery. And then in those two regimens, the pembrolizumab and durvalumab neoadjuvant regimens, then in the adjuvant setting, they get just the immunotherapy. So they get all their platinum-based chemotherapy in first. So I think both of those regimens, they're new, and they're exciting. While the drugs aren't new, it's a new space where we're looking at using it.
Awesome. Definitely exciting to hear about all these updates that have occurred only within the last year or so. Definitely a lot going on in the space.
Mhm.
Just switching gears to immune-related adverse events a little bit. When you're monitoring patients who are receiving immunotherapy, are there any particular risk factors that you keep in mind?
Sure. I mean, certainly things like autoimmune disease, and that's probably one of the biggest things. And, that can range anywhere from like mild eczema to, Crohn's and severe colitis that people may have. So, you have to really weigh the risks and benefits. And I think this is another area where, um, in the metastatic setting, we may be a little bit more likely to push the envelope because it's not curative intent therapy. But in that neoadjuvant and adjuvant space where we're giving them curative therapy, especially neoadjuvant, we want them to get to surgery. That's their curative intent modality. So I'm probably less likely to push those patients, who may have a bad psoriasis or, significant colitis, like a Crohn's type disease, because I would be hesitant to give them such bad immune related toxicity that they didn't make it to surgery. Um, but that being said, well controlled rheumatoid arthritis, well controlled autoimmune skin conditions like psoriasis or eczema, things like that. I think I'm a little more likely to still give it and monitor, kind of going in eyes wide open approach and saying to the patient, hey, we're going to really have to monitor this. Um, and then outside of that, immunotherapy is pretty well tolerated. So outside of those risk factors of autoimmune disease, we are giving this to most patients. Now, the other thing that falls into the autoimmune disease category is organ transplant. So this is something certainly in the neoadjuvant space I would not give to patients with organ transplant. Yes, you can argue a little bit in the metastatic setting, but certainly wouldn't want to risk them rejecting their organ.
Definitely. Good to know. So one of the things that Blanca talked about in the activity was the importance of being proactive versus reactive when managing adverse events. Would you like to speak a little bit about that?
Yeah, I think it's important for patients to know sort of how the drug works without getting too detailed into the molecular biology of it, but talking to patients to say, hey, in general, your immune system becomes inflamed. And sometimes that can cause inflammation of really any part of your body. And I may touch on, especially in lung cancer, where we have a little bit higher rates of pneumonitis than other cancers. I'll say, if you're short of breath or having a really bad dry cough, you need to call us. You would hope they would anyway. But you sort of give them that, background. Um, it's hard to give patients a list of every single itis that can occur. So a lot of times I'll say, if you have really bad diarrhea or significant shortness of breath, to give us a call. But really anything can become inflamed. So give us a call if anything's wrong. If you're finding like mild confusion, call us. If you're finding, that you're having palpitations, call us. If there's a minor rash that becomes a lot worse, call us. Just call us for anything. And then I say, we'll tease it out and ask you more questions to find out if we think it's from the immunotherapy versus something else. So I think being proactive and teaching our patients that way, to call us and let us know.
Absolutely. So as new treatments are coming into practice, how do you try to stay up to date with supportive care strategies?
Know that supportive care has changed a whole lot with our run-of-the-mill, PD-1, PD-L1 anti-CTLA-4 drugs. I mean, again, in general, like outside of rashes where we'll use topical steroids, oral steroids are often the treatment of choice for anything that's symptomatic, like grade 2 or higher. So, and then of course, outside of the endocrinopathies, the things like hypothyroidism, hypophysitis, those are things that we will supplement the hormone in question, whether it's levothyroxine or hydrocortisone, whatever it may be. So it's really changed a whole lot with that. The one thing I'll say here is, I mentioned earlier that we now have a bispecific T cell engager, tarlatamab, approved for small cell lung cancer. So that falls sort of into this immunotherapy space. It is a T cell engager. And so, but with that, we're seeing more CAR T bite therapy type side effects, such as cytokine release syndrome, the CRS, and the neurotoxicity such as ICANS. This is something totally new to those of us who specialize in the solid tumor space, especially lung cancer like myself. And the CRS rate is pretty high. It's over 50% in these patients. So we're starting to learn how to assess for and manage cytokine release syndrome. ICANS was less common in this. I think, only about 5% or less. So, but something still to know, because if left unmanaged and untreated, can become worse. So I think learning now about how to manage these types of things. I mean, we've been taught about these at other conferences, but some of us in the solid tumor space probably tuned out a little bit because they're like, oh, well, we don't use those drugs. That's all liquid tumor. Now we are using them. So we have to be aware. Outside of the itises now is the CRS and the ICANS that's associated with these therapies.
Absolutely. So as we wrap up, since this activity was geared toward nurses, do you have any advice specifically for nurses and nurse practitioners about what a critical role they play in treating and caring for patients receiving immunotherapy?
Yeah, I mean, nurses and nurse practitioners are the first line phone call. So we have a whole triage nursing team where I work, and they are absolutely the first line. And so they know what questions to ask. So it's really important to know what questions to ask to tease out whether or not you think this is from immunotherapy versus something else, like from the disease or the chemotherapy. So we need to make sure that we are going to our conferences, doing our online education, our webinars, what podcasts, whatever it may be, to make sure we're understanding what these new therapies are, why they're being used, what setting they're being used in, if patients are neoadjuvant versus metastatic setting, and then understanding how to manage, what to look for, first of all, and then how to manage these toxicities.
Absolutely. Well, thank you so much again for coming on today to share all these updates with us. It was great to hear about these new advances and your perspectives in the area. And I encourage everybody listening to check out the activity on the Arthur Health website to hear more perspectives as well. So thank you again.
Thanks, Kira.